Let's talk about clinical reasoning and let's have a realistic discussion about what we can do as physical therapists. Let's imagine we have a patient, female, professional soccer player, who's torn her ACL. It's a grade 2 tear of the ACL. The surgeons want to do surgery, understandably, but due to personal or religious reasons, she doesn't want to have the surgery. She wants to have it managed conservatively. They arrive at your door with a referral, grade 2 ACL tear, assess and treat. What are you going to do? Well, let's think about the biopsychosocial nature of this patient's condition. We'll talk about the biology in a minute. Let's talk about the psychology of it. She's a professional soccer player. She doesn't want a reasonable outcome. She wants an outstanding outcome from this ACL rehabilitation. Social. How will losing her ability to make her living as a professional soccer player be affected if this rehab doesn't go well? So psycho and social are an important component of biopsychosocial. Let's talk about the bio. What technology can we use as physical therapists to speed up the healing of a grade 2 tear of the ACL? Can you dry needle it? Probably not. Can you use ultrasound? Probably won't get the depth. Could you use interferential? You could. It's questionable as to whether or not it's really going to get deep enough to have an effect. Could you massage the ACL? No. Could you manipulate the knee? Probably not. Probably not advised, right? The only thing that I can think of technology-wise which may still help, which you may or may not have one floating around the clinic, is the old shortwave diathermy machines, which were able to bang in a lot of heat. So what can you do as an orthopedic manual therapist? You have to appreciate that there's a certain concept called the tincture of time. A tincture is a medication that's made up into a paste using different medications to apply to an area of an animal's body. The tincture of time is you have to allow time for the healing to occur. But there's much that can be done in the meantime. You can ensure that your patient has good facilitation of her quads and hamstrings. You can ensure that the patella continues to track appropriately as the ACL heals at its own rate. You can ensure that the joint movements, including flexion, extension, flexion adduction, flexion abduction, extension adduction, extension abduction, and all those components of flexion and extension are in a good state of affairs such that when the ACL has healed, the patient has normal range of motion and good quality muscle strengthening and control, right? So we have to go back to the neurophysiological connection between the brain and the muscle to ensure that she can facilitate the muscle, that she can recruit the muscle, and that the muscle can give graded contractions as necessary dependent upon the task specific, right? So what's the final discharge criteria for this patient once the ACL has effectively healed itself? Because as I said, there's not a lot that we can do to change the environment in which the ACL is going on. You could make the argument that nutrition's important and stress reduction and not re-injuring and all those issues. That's all fine, that's all part of the management, right? So what's the final discharge summary for a professional soccer player? Is it Cybex quads hams ratios or Bidex quads hams ratios? Is it the ability to hop or jump across your clinic floor? No, it's to go out on a soccer field and run full speed and stop and cut left and cut right and pivot left and pivot right and get the ball. So just think about the multifactorial nature of every patient you see. There's a bio, there's a psychological, and there's a social component to every patient. Think about that and think about that in terms of the patients that you see today in your clinic.